move into our final session of our two-day symposium entitled How Can Practice-Based Research Advance Post-Pandemic Population Health in New Jersey? I am serving as your moderator / MC, and I'm going to start off by doing a quick presentation of what the New Jersey Practice-Based Research Infrastructure, network infrastructure looks like. So Oliver, can you pull up my slides for that? Thank you. And so, as promised from the title of our catalyst, I want to introduce you all on the Zoom to our New Jersey Practice-Based Research Network. Next slide. So I know that you heard yesterday, but for those who weren't able to join, this is a recap. Like, what exactly is a practice-based research network? You've heard from our many speakers today some examples, but to pull it back up to that 30,000 foot level, the formal definition is that they are groups of clinical practices working together to answer population-based healthcare questions. A PBRN is something that serves as an infrastructure to link practicing clinicians in the community to experienced investigators, typically in an academic health center or university setting, such as ours. The concept of a practice-based research network dates back over 30 years, so it's not something that we just invented, and they've been largely supported financially and infrastructurally by the U.S. Agency for Healthcare Research and Quality, or AHRQ. The registry maintains approximately 185 PBRNs across the country, which have different sorts of forms and functions. Some of them are focused on specific service lines, such as dentistry. Some of them are focused on regions. Some are focused on states, such as ours, and some are more national. Next slide, please. So the NJ, New Jersey PBRN, is depicted here graphically. This is also available in the online packet, which we've been trying to put on the chat box. But if you haven't had access to the Catalyst packet, feel free to reach out to us afterward. But in short, the NJ PBRN sits between New Jersey researchers and New Jersey clinical practices. And the infrastructure itself aims to provide technical assistance, training, and education with potential opportunities for continuing education. And at the end of the day, we are trying to coordinate the work that's being done by our research scientists here at Rutgers and at other universities across New Jersey, and the clinical practices to make sure that we can facilitate all of the great work that we're all doing previously in silos and hoping to bring us all together under a network umbrella. The researchers themselves are bringing the innovations, such as the mindfulness mobile apps, to the table, methodological rigor, and study incentives, which are often coming through national or federal and foundational grants, and could be financial incentives or tools or external care coordinators. The New Jersey practices serve as study sites and can participate where relevant and meaningful to them. And what's really important to our mission within an NJPBRN is that the practices have opportunities to provide practical feedback. So some of the gaps in translating evidence into practice is that maybe the right questions aren't being asked at the front end. So we would love to have practices and clinicians and practice members work with researchers as we are developing these research proposals and make sure that we're targeting the areas that you are all interested in and the questions that are actually meaningful and relevant to you and your patients. And the end of this is the goal is to improve care quality, help with practice transformation, align clinical work more to health reform efforts, and then help manage population health in our state. Next slide. So summary about why participating in PBRNs is important. Efforts are working because we're seeing across the country strong academic and PBRN partnerships leading to improved quality outcomes for patients and improved practice operations. There's strong community engagement that happens through PBRN partnerships. We hope to work more with the IFH community's community health engagement arm. And we're also hoping to engage more with existing PBRNs across the region and the country. Yesterday, we had a great panel of speakers who are directors and investigators from PBRNs across the country, which we hope to continue engaging with and disseminating the work and broadening the work that we do here in our state to the national level. The keys to success of a PBRN include having diverse participants, including clinicians, staff, and patients, offering through our network protocol-specific topics through education, and offering timely, relevant continuing education. Key barriers to participating in PBRNs include that we've heard this time and again that there are clinical demands and productivity that may preclude clinicians and practices to participate. And the network aims to reduce some of that barrier by taking over some of the administrative overhead and offering the training and education needed to facilitate that. There may be competing priorities. Well, that's where we can help to alleviate some of the administrative burden in participating in practice-based studies. Let's go on to the next slide. And then what we're hoping to do by participating in PBRNs is that this network can help increase retention and recruitment for researchers, can provide professional development opportunities for practices, training education around how to conduct practice-based research and what are the elements around conducting research period with regard to maintaining human subject IRB compliance and HIPAA regulations, to making sure that what we do is protecting the patients and the providers involved, diversifying different sorts of roles for practitioners and their staff who may be wanting to work more at the top of their skills. This is how we can offer different sorts of training education to enable to do so. And ultimately help, our goal is to help increase job satisfaction for researchers and clinicians and staff at practices alike, to be able to get them out of, to be able to inspire their intellectual curiosity and to give them more of that time back to enhancing population health overall. And the goal of the PBRN is to improve clinical skills, guidelines, and best practices adoption and clinical quality through these research projects, and decrease, again, the implementation time, stress, and burnout that may be related to having to do this all themselves within their isolated practices, by bringing them with, connecting them with researchers and other practices that are interested in doing similar quality improvement, quality assurance work. Our mission here at the NJPBRN is to improve population health and equity for all New Jerseyans through practice-centered research, education, and dialogue. And our next slide. And our vision is to increase the presence of New Jersey clinical practices in academic research. We are trying to include not only primary care, but also medical specialties and surgical specialties, hearing that the integration of our healthcare ecosystem is essential to improving population health. And so we are formally, officially launching this network this month through this Catalyst event. So I'll go ahead and conclude my slides here, Oliver, and then just close out the slides. And then I'm going to introduce our esteemed panel of speakers. So in no particular order, it's just how I have it lined up in front of me right now, is Mary O'Dowd. She is the Executive Director of Health Systems and Population Health Integration for Rutgers Biomedical and Health Sciences. She was a former New Jersey Health Commissioner, and more recently, she launched a podcast series called On the Pandemic, which I highly recommend. Listen to it personally, and you can find that on Spotify and I'm sure other avenues where podcasts are disseminated. So she, in the podcast on the pandemic, she engages university experts and New Jersey health leaders in conversations regarding critical challenges in the recovery from the COVID-19 pandemic. So she is a perfect person to have on this panel. Thank you, Mary, for being here. Next up, we have Dr. Yanai Krasler. He serves as the New Jersey Department of Health Director of Population Health. Population Health at New Jersey Department of Health supports the struggle for health justice through meaningful data, community relationships, and partnerships with state agencies, local public health, and community-based organizations. He is so well positioned to speak to what is happening in our state and how practice engagement can help facilitate practice improvement. And then last but not least, we have Dr. Kemi Ali. She has been the CEO of the Henry J. Austin Health Center, the FQHC, down in Trenton since 2015. She previously served as Chief Medical Officer from 2008. She has been a pediatrician with Henry J. Austin for over 22 years, and she obtained her medical degree and completed her pediatric residency at the Robert Wood Johnson Medical School. So we are proud to call her an alumnus. So Dr. Ali, thank you so much for being here. Also to speak about safety net settings and what you have seen on the ground serving our patients in New Jersey throughout and hopefully as we move past this pandemic. And so I have a prepared list of questions, but anybody who we encourage this to be an interactive panel. So if you have questions, feel free to put them in the chat or raise your hand and we will try to integrate them during this session. So my first question is, so we've heard from the speakers throughout our event that care delivery will be different as we move past the pandemic.
Yeah.
From your perspectives, I'd like to hear what are some long withstanding impacts of COVID-19 on how ambulatory care practices will deliver care in our state. So I'm going to call on Dr. Ali to speak first.
Yes. So good afternoon, everyone. And again, thank you for this invitation to speak with you today. I feel very honored and privileged to speak with everyone. So as we know, the COVID-19, it's been a very interesting journey over the last 14, 15 months. And the disruption has been very unique, in particular for inner urban city clinical practices. One of the challenges with the beginning of the pandemic was how do you see your patients? Face to face was a very scary time at the beginning of the pandemic. And so many organizations moved to providing medicine through telehealth. But as we know, in urban communities and even specifically in rural communities as well, there's challenges with telehealth. And I think that's one of the impacts that we will see even going forward, that there are definitely pockets of communities, of individuals, of populations that don't have the access to the same connections for various reasons, whether it's broadband, whether it's technological education and savvy, many different reasons. And I think that's going to definitely be one of the impacts even as we go forward. And how do we address that? I think wearing my physician hat, the other impact that we'll see around COVID is what's called sort of the post-COVID ICU syndrome. And in particular, because so many individuals that were impacted and infected by COVID were of brown skin color, African Americans, Latinos, we're going to really see that impact as we go forward. So as we think about treatments and strategies and therapies, this is the perfect kind of clinical-based practice research that we could be doing to determine what's going to be an effective strategy unique for those populations.
Great comments. Yanai, I'm going to call on you to answer the same question or build off of what Kemi had said.
Yeah, no, thanks so much. And just, again, like, thanks very much for this opportunity. And you mentioned, Anne, like, kind of the from the state side, having the visibility into the practice and into the good work that obviously both Mary and Kemi are leading, and the folks on the call. It's over the course of the pandemic, to be able to work, like, let's say with Dr. Ali's team, like on a Saturday afternoon around how many vaccines they will need in order to ensure that vaccines are going to be accessible to people experiencing homelessness, like by the allocation deadline, or to be presenting something, let's say to the professional advisory committee for vaccines, and to just observe Mary like pleading for the registration system to be easier, just make it as easy as possible. And so it's, and I think that I guess from my perspective, it elucidates the importance, certainly from the state side, as trying as much as we can to listen to what our providers are sharing with us from the ground, and to utilizing practice-based research as a lens through which to listen, and to value the place where providers are listening to their patients and working together with them to create the system that we all dream of. So, firstly, just kind of the deepest gratitude for this opportunity, and of course, just to the providers on the line for literally holding the world together during this period. From an ambulatory care perspective, obviously, like Dr. Ali mentioned, the overnight pivot to so much more reliance on telehealth and remote provision of care has been such a monumental change that hopefully we'll be able to incorporate long term. Another one is better flow of data from provider to provider, and then of course back to the state, and a muscle that we need to learn to flex on the state side is to be able then to disseminate, to provide that data back more broadly so that we can identify trends and inequities. I think another point that comes up for me in this space, infrastructure wise, is kind of like almost, and I feel like Dr. Ali sort of as an Henry J is like, this is what you guys do, right? But it's like kind of like a no wrong door to care point of view. And there's like two directions there. From a COVID point of view, it was like any specific service that was provided by a Henry J, for example, or a hospital or an urgent care, then became an important linkage point to primary care, to social support services, to substance use treatment, to any type of treatment, right? Like that low threshold that I think you guys do so well. And then from the opposite direction, if somebody is coming in for another purpose, whether I'm coming in for my food delivery or for my linkage to shelter or to substance use treatment, then that can also be a point at which I do a screening, let's say for COVID, or get a vaccination. So it's like, it's just kind of hopefully we can maintain the system and the relationships that have been cultivated over the course of the pandemic, and just kind of hold on to them as we move past this.
Yeah, I hope so too. Mary, your thoughts?
First, thank you for having me. It's wonderful to be on this panel. I've only met Yanni from my work on the Commissioner's Advisory Committee during COVID, and Kemi and I are both on that and have been long friends since she was the medical director at Henry J. I feel like that's what you were when we met, but it's been like 2008, so a long time. So, when I think about this question, I sort of have four buckets that rise to the top. One is operational and health delivery system stuff. And one of those things is telemedicine. We've talked about that. Lots of people are talking about it, and there will be activity on it. So I think that's one of the areas where we could focus, and we can use it, understand where it doesn't work, understand where it does work, and then maybe figure out how to use it most effectively. So I've heard some information about, we talked a little bit about where it's not working. Kemi mentioned that. But one of the areas where I've heard that it is working is in mental health for teen and young adults, where they won't interact in person, but yet are able to communicate their most inner private thoughts on technology. So some of us don't relate to that behavior, but in some sort of anecdotal conversations I've had with behavioral health providers, they've said this was eye-opening to actually reaching a population that they felt like they weren't being effective with in the past. So I think that's a sort of a silver lining that we should identify, figure out where it works well and where it doesn't. I gave my personal experience earlier where, I went to an in-person visit in the last year where the doctor was like, well, we should have done this during telehealth, but we hadn't even thought about doing that. And then a pediatric experience with one of my children where it was less than ideal as he was climbing on me and I'm trying to hold the screen and it was a little chaotic. So there are going to be places where this works well and where it doesn't. And we should figure that out and double down in the areas where it's an effective tool and try to figure out other strategies where it's not. I do want to note, and this is my high-tech screen share, that there is a report out there that's been co-authored by BioNJ and the New Jersey Healthcare Quality Institute, where they highlight the need to have a conversation about the laws and payment on telehealth. And they specifically note that this, review commission should be convened and it should include healthcare policy researchers on the panel. So I just wanted to highlight that because I think as the state's leading academic and both in healthcare and public health center, Rutgers really needs to make sure that they're at the table for that. And I saw Joel on the list of participants, so I'm sure he's involved. The The next bucket is evolving needs. I think very much around mental health and resiliency in all areas. And this is sort of emergency preparedness, the fourth chapter, right? So it's how do we really think about addressing the trauma in all the different ways that we have experienced it as parents, as patients, as providers, as a community, and think about that. And then also, how do we build resiliency, not only into our systems, but into our individual selves? I think workforce has been highlighted in this pandemic, both our healthcare and public health workforce, how important and critical they are, and how we need to care for them. And so often we see studies that show that they are not caring for themselves. We see this in various populations, but I think in particular, we want to make sure that they're accessing those support services that are being made available to them so that they can recover and be resilient. And we need to think about caring for them as we look at this and making their lives easier as they save ours. And then the last is, what is old is new again and worse. So all of the stuff that we already knew about inequities and disparities and access issues and challenges, we only saw that exacerbate during this pandemic. So whether it was the fact that we know we have problems with chronic disease management and burden in different populations, we saw that hit us harder during the impact with COVID. We also saw the issues of ensuring and enhancing access to screening and preventive services. During the pandemic, we saw childhood vaccinations plummet, lead screenings plummet. This will only further exacerbate our existing inequities and disparities in outcomes. And so we have to really think about that critically as we recover from this. And then also lost or missed care. Cancer screening, for an example. Someone mentioned colorectal screening earlier. And so really thinking differently about how to address those issues in our various populations and how to make it easier, more effective for the provider and the patient, and really think about that. These are not new problems, right? These are not new. They were just highlighted or exacerbated as a result of COVID. So.
Thanks, Mary. You actually just touched upon what my next question was, and I see everyone nodding because my next question, just to read it off, is the pandemic shone a light on health disparities and that we knew were present. What you're saying, what is old is new again, but worse, in our very diverse state. And those disparities were exacerbated during the pandemic. And so this is a little bit redundant with overlapping, but I'm curious about what other folks think here on our panel. What have we learned regarding health disparities during the pandemic, and how can practice-based research mitigate those disparities or start to address them at least? And so I don't know if Mary, you wanted to add anything more to that.
Sure. I think we can try to understand some of these inequities better. I think that's where this practice-based research can be effective, and the breadth and depth of what you are building is really important so that we can see population and cultural differences in different strategies, and are they effective or not, that we can see delivery strategies. So is the large academic practice or the community-based one provider or an FQHC, where do they work better and how? The diversity of implementation can be compared and contrasted, and we can figure out how different tools will work in different environments more effectively. And then what are the real barriers for patients and how can we address them? I mean, I think about just the idea, I'm overdue for my mammogram. All right, I'm going to admit it. It's a problem. I need to get in there, but I need to also schedule childcare for that day and get myself there. And, I'm in a hybrid school environment, so I have to pick up my kid in the middle of the day. So all of those realities that go along with being a mother of small children is a barrier for me. That's going to be different for every population. And so understanding and truly understanding those barriers from the various perspectives, and then how do we address them, is going to be something that this network can really look at in a meaningful way and then present evidence-based solutions to those problems. And so, again, these are not new problems. And I know from the various seats I've sat you're always dying for that answer of, well, what will work to address this problem? Because you so desperately want to do it. And I'm sure my colleagues have things to add to that.
Kemi, any comments about that?
Yeah, I would say, Mary said it very well. And I also think, so how can practice-based research mitigate some of these disparities? And I think what's unique about the practices is that they really are connecting with the individuals that you want to have the outcome. So that's that unique opportunity to really be inclusive and have them be active participants in the creation, in the thought, in the strategy behind what's going to be effective for them in their communities. And that's where I think the practice bases really shine. I mean, the whole pandemic, as Mary said, has shown that light on disparities, but more even so, really this overarching structure of lack of trust in the healthcare system in all its facets. And in particular for African Americans or African American descent. And their history is very unique, right, as it relates to trust of the healthcare system. And as a result of that, it really has shown the importance of engaging and communicating and building relationships with every facet of our population. Because as we see now, if you thought, oh, that was their problem, they have this historical issue and trust, they have biases within the African American community, but that doesn't really affect me. COVID has shown that, well, if that population has so much distrust that they do not get vaccinated, that now affects everyone. That affects our economic institutions as well. It has this rippling effect across our country. And so really working with those populations, working with those communities, working together to develop treatments and strategies and thoughts, which will hopefully build trust, then you really can have population health and population improvement in historical communities, historically where it's been really challenging to do that. And again, I think practice-based research is a perfect forum for all of that to happen.
I just want to highlight one of the things that Kemi just said was raised yesterday by one of your presenters, the federal guy, the federal quality guy.
From HRQ, Bob McNeilis.
Yeah, and he said, if FQHCs had been at the table when they were developing the federal rollout plan for the vaccine, it might have looked a little different, you think? And so I think what Kemi is saying there is critical, that having the providers and the communities frame the research questions rather than just thinking what we think and then asking our questions and then delivering them the answers that won't work. Not that that always happens, but it happens frequently enough. That having them at the table in the beginning to design and ask the questions will make it very different when we get to the rollout. Yeah.
Great points, because and I've emphasized that to do population health, you really need to keep a pulse on the population, and there are very few people who know better about their patient populations than the practices themselves, that have that relationship with their patients. Yanai, any comments?
Yeah, no, I mean, agreed on all fronts, and it's like, especially that piece around working together in program design, or in care design, in clinical redesign. If I'm kind of quoting our friends, let's say, like at Camden Coalition and beyond. When we had kind of conducted, we've been doing a lot of like listening sessions and interviews, and there's always that point around, you ask your questions and then you never come back. And if from the beginning that engagement is happening at a consistent level, so that we're actually co-designing with the people that we serve, that's critical. The gaps in infrastructure, the gaps in access have been devastating from the beginning of this. The barriers to partnerships, the opportunities for partnerships have been just abundantly clear. And I think that practice-based research, it becomes a window into like breaking down just some of the jargon into the ways that, like what does it look like to enable access to the social determinants of good health from from the perspective of a local practice, and what does the partnership with the state or between the state and the different stakeholders in an ecosystem, what does a supportive partnership look like, or where are the specific pain points? Like, I think that, I think we all come to this space desperately wanting to de-silo and desperately seeking health justice and health equity. But I think utilizing a lens of practice-based research helps identify where those pain points are and what the specific solutions can be. And just entering it from that place of humility where everybody at the table is an equal partner in design enables almost like a solidarity in chaos. That I think that we're, again, just kind of all I'll just in search of here. I think one more point, and Dr. Ali, kind of some of your points are bringing this up for me as well, is like, there's a lot of work on our end, both stateside and on the provider side, around addressing implicit or explicit bias in healthcare, discrimination, racism, all forms of discrimination in the way that they're manifest in healthcare. I think practice-based research is a way of, again, just kind of like breaking down what does it look like for racism to be manifest in an encounter. And I think one of the like painful things to see through the research is how these really are systemic, how it's not kind of, like a one-off interaction, but especially when systems are under stress, as they have been, obviously, like never before in a pandemic, then that's when some of those, that's when those pain points kind of bubble over. And so ensuring that we have the pulse of those through practice-based research and through participatory research together with the people that we serve, hopefully we're able to just kind of grow from those pain points, identify opportunities, and just kind of get better at this. Because these are, I feel like for all of us, this is what keeps us up at night and gets us up in the morning after not a good night's sleep, and as it should. This is what brings us to work. So I think that there's so much to learn from this process.
Yeah, no, to build off of that, what this network we envision to do is to be able to learn about this on a large scale. So to be able to test, let's say, a social determinants of health screening tool, not only in one FQHC, but let's see how it manifests itself in many of them, or in different types of practice settings that located in different parts of New Jersey, the South versus Central, or North Jersey, different communities of color. So there's so many different ways that we can adapt these different innovations that we have into different settings, but we can't really get at that until we get into the practice settings themselves that have these different types of patient populations. And so this segues really nicely into my final formal question for the panel, which is about partnerships. And so we saw many new types of partnerships formed during the pandemic, and it shows that we can do better together than in silos. Forgive me for being very cliche about that. And that's part of our mission here with the network, and really just what we do as a public university, to help researchers and practicing clinicians come together at the same table. So moving forward, what opportunities do you all see for researchers and practices clinicians, the community, to work together more to improve population health in New Jersey? So I'm going to call on you first. Given your position at the state level, what sort of opportunities you see for more partnerships, and which of these, how do we sustain them? I think you alluded at this earlier that you hope that they sustain. What are some strategies that we can do that?
No, that feels like the critical question. I think that people have really come together in beautiful ways over the course of the pandemic, and how do we hold on to them moving forward? It feels like such a life-saving question in this space. I'm thinking of just starting with thinking of critical partnerships, sort of, and I think that there have been so many in so many different spaces, but at the state level, so I've been working very closely with my kind of dear friend and colleague at DOH, Natasha Rosario, who I'm sure a lot of you guys have worked closely with on the overdose front. But we've been working, together, of course, Dr. Ali, with your team and other providers, and and certainly with our sister agencies, Department of Human Services, Department of Children and Families, Community Affairs, HMFA, specifically around pandemic response for people experiencing homelessness and survivors of domestic violence, and the consistent ability to work to work with our sister agencies at the state has been extraordinary. And again, to come to these, kind of like weekly, at times it was daily or every other day, kind of like calls, and to come to form a team, like an interagency team, where it doesn't feel like we're part of different agencies anymore, but problem solving together, working together with providers on the ground, partnering, I think, with community-based organizations that have just done heroic work, thinking of like local public health and the extraordinary work that local health departments, and a framework that I think our colleague at the state, Shireen Semple from Office of Local Public Health, together with health officers across the state, like they've created a system for local public health, I think, to be responsive through partnership and through really like reinforcing the importance of local public health working together with community-based infrastructure and healthcare infrastructure. I think it can't, like the work of the federally qualified health centers over the course of this pandemic, like literally from the beginning, and like really seeing FQHCs as a backbone, as the backbone to health equity in the state is an important piece of this that I hope that we can hold on to and ensure that they have the support that they need, that they deserve to do the critical work that they do. Some specific mechanisms that I think have enabled, hopefully, sustainability in partnership, like learning collaboratives, and I think that connects obviously with practice-based research, but we participate, I think it's a high point on a weekly basis. I almost called it a holiday because in some ways it feels good, but it's a learning collaborative that we have that was set up by Bob Atkins and Diane Hagerman from New Jersey Health Initiatives, together with Robert Wood Johnson Foundation. But it's a learning collaborative of community-based organizations that are doing work to ensure vaccine equity for community-based organizations. And it's on a weekly basis, and literally, and it is everybody coming to the table on a weekly basis, bringing up both their challenges and high points from the week and troubleshooting together. And extraordinary, just kind of specific solutions have, I think, emerged from there. I think we're trying very much, we've got like, I think the learning collaboratives project echoes a lot of the work like that, I think, become sustainable anchors for solidifying some of these partnerships, ensuring that partnerships aren't just partnerships, but are also opportunities for learning together. I think data infrastructure is another way through which partnerships can be solidified. So, the regional health hubs, the role that they play locally, certainly in managing health information exchange, the work that NJPBRN is doing around the HIN. I think kind of the more that our data can be integrated, the easier it is for us to communicate about the same data. If we're talking about the same numbers, then we can work together to address problems. And if we don't feel like it's, these are your numbers and they're pointing to you doing stuff wrong, but rather these are numbers representing our collective responsibility to do better, then I think that's another one as well. And then maybe just a last piece before I pause. Gosh, there's so much. But in the practice-based research landscape, I think emphasizing the importance of qualitative research too, like when we say data integration, so to ensure that we're also talking about qualitative research, immersive research, the creation of research teams where both providers and patients and state workers like are thrust into a place where we have to learn from the work that we're collectively doing together. Those are what come up for me immediately. And I'm excited to hear what Mary and Kemi have to say as well, because you guys are on the ground, you're doing this work, and yeah, there's so much more.
Great answer. Kemi, go ahead.
Yeah, so as we move forward and you look at what are those opportunities for researchers and practices to work together to improve population health, I think, as we've said, it's just such an interesting time that this pandemic not only is it this tragedy that's brought so much sorrow, but on the other hand, just the light that it did shine on opportunities and people embracing those opportunities like never before, as Yanai is saying. I mean, an example for in Trenton that we met daily for the first 4 months, and we pulled all the community stakeholders to brainstorm together. So as Yanai is saying, I hope that commitment to partnership is sustained. And if you say how and how is that possible, I would hope that because of the light that's been shown on the inequities and the disparities, many people are now talking about it like we are today. But more importantly, Many people are now putting the funding stream behind that, so that we can sustain these partnerships that we built together. So just the other day, Henry J. Austin was very fortunate to receive a grant from the Bristol Myers Squibb Foundation to really embark on becoming a research hub, which is probably why I'm here. And so the idea is just that. We've been communicating within our community for the last year. How do we now institutionalize that? How do we build structures? How do we build form around that so that years to come it's sustained? How do we take what we've learned, what we've experienced in our partnerships, in our collaborations, and really form structures around that? So no matter who comes and goes, there are now institutions, there's collaborations, there's networks that will continue this great work moving forward. Again, I think and I hope, as Yanai is saying, this is the opportunity. And for the first time in many, many years, there is now resources and funds and people with the want and the will to want to make this a reality. And I think that's the important piece here, is that not only do you have the want and the will, but now you've got the resources as well. And the two of them are coming together, really built on this sort of very organic collaboration and networking and partnership. So again, I'm very hopeful that it will be sustained in the future.
Well, first, congratulations on the grant. That's very exciting for Henry J. Austin and for you, I'm sure. And I want to point out, like, let's not discount the power of relationship building. So those daily meetings that you had for 4 months, even if they don't sustain as daily meetings, they helped enable us to connect and see what one another can do together. And the next time, like, if there's anything that comes up, you can call on that organization or that partner, right? And then last but not least, I'm going to hand it over to Mary to comment on partnerships.
So I would say that we want to look at what exists in maybe its early forms and then double down and invest in those. And so, for example, Kemi is on the Trenton Health Team, which was something that was born back in 2008-ish, I think, under duress by the health department because of a hospital closure. And so over time, that was small investments were made, and collaboration began. And now it's this thriving model of how to collaborate in a city like Trenton for healthcare with FQHCs and community providers and community, the public health, local public health, and the hospitals all together collaborating. And I think, now with funding available for recovery, resiliency, rebuilding, mental health, all of those things that they've been working on in a variety of different ways, using those resources to invest and build upon some of those existing partnerships is critical. I think the Health Information Network that you highlighted today is another example of an idea that was launched a long time ago, and it's amazing to see how it's grown. But one of the areas to really think about is its use of the immunization network, for example, that was used as one of the key mechanisms for the vaccine strategy in the state. How can we now maybe enhance, rebuild a little bit, that existing physical infrastructure of a technology tool to be a broader tool for the benefit of a population that now has used it a lot, right? So now we have a lot of people's information because almost 60% of New Jerseyans have gotten at least one dose of the vaccine, which means their data is in there. We've never had that happen so quickly before. And so I think, thinking about that strategically. And then the last thing I would say is, and this is probably to the Department of Health a little bit, is that sometimes it takes thinking outside the box with some of the federal funding opportunities to really explore long-term solutions. So with Superstorm Sandy, public health was not in the forefront of people's minds or the federal government's. And so it took a lot of effort and frustration on my part to think differently about how to broaden what we understood about post-hurricane public health issues. And so we did build upon some of the things that we were able to find from Hurricane Katrina, and then invest in research with our academic partners. There was a child study team specifically looking at the effects of the trauma and the storm on children 5 years out. So to keep looking at that. And it took real aggressive behaviors at the health department to think about using those dollars in that way. And the Rutgers School of Social Work was a partner in that research. And it allowed us to keep our minds on 5 years out, what was still impacting that population. That's not necessarily what government officials want to hear. And so it took a little bit of maneuvering to do that, but there isn't enough research out there about post-traumatic events in large-scale populations and what works and what doesn't to build resiliency. And now we're having a lot of funding come to a lot of different communities around the country and the state quickly. And so I think we really need to think about how to study the implementation of those programs so we understand for the next event, because sadly, everything that has happened here in the last year was predicted by public health experts. And so that we are better prepared for the next event. And so I think, incorporating evaluation and research as part of our strategy with this funding is a really important step that we can do, because it helps us be better prepared and be more resilient.
Mary, I'm so grateful that you mentioned that at the end and all the points, but including that one at the end around lessons learned. And I know that there are a bunch of different frameworks through which this is coming together, but just one of them alongside the others that we are trying to utilize specifically for that purpose is Healthy New Jersey and the state health assessment, state health improvement plan, and very much hoping that can be sort of a place through which a lot of these kind of best practices that have emerged or opportunities to better learn what worked and what didn't work can live and then be reflected back. So that's definitely a place, and your kind of question started with partnerships. Mm-hmm. Healthy New Jersey, which is kind of the New Jersey version of like the federal Healthy People, is a place that it does rely on partnerships. And so that's hopefully a place through which a partnership and research-based approach can ensure that a lot of those lessons learned are held onto. And just two additional points that I wanted to mention as well. Just one is, I know you both mentioned the importance of just kind of addressing the trauma within healthcare, and definitely want to just emphasize the importance of including like public health infrastructure in there as well. And it's a different form. It's a different form of trauma, but it's there too. And I'm hoping that that's also like a kind of a collective partnership that we can engage in as well, and to really be there for the folks that just have done so much over this period. And then finally on the partnerships front, and you mentioned relationships, but that kind of like partnerships to relationships to friendships, and hoping that a lot of the kind of friendships in this space that have been cultivated like can also help create sustainability in partnerships. Like friendships are more durable than partnerships, So I'm hoping.
Well, thanks for ending us on such a positive note, I really enjoyed talking to all of you. I'm going to invite the audience. If anybody has a question, feel free to raise your hand and we can call on you to unmute yourself. Or also feel free to put it into the chat. As you're all doing that, I just want to summarize some of the keynotes that we had heard from this panel here. Is that, again, it's all about partnerships, trying to sustain those, building out those relationships. And you highlighted all of you highlighted many different target areas that we can continue to move forward and try to advance in terms of health equity and population health in our state. Some of the areas that I heard a lot about was telehealth and making sure that there's equitable access to different communities, making sure that the workforce is not forgotten as we move forward, and taking care of our patients, is that our patients are taken care of by our health workforce. So making sure that they have the the care that they need to make sure that their stress and their burden isn't going to overwhelm them as we move into this post-pandemic period, and trying to pick up all of the care that fell through the gaps, frankly, during the pandemic, that will probably manifest itself in ways that we may be somewhat anticipating, but only time will tell what the long-term effects are from the pandemic. And finally, just the idea that we can do more to collaborate. There are a lot of existing infrastructures, the data infrastructures, the partnerships that you talked about, new opportunities for research and funding that Kemi, you talked about, and with your grant that you're going to be able to even start up your own research arm at Henry J. Austin, and Mary, and all of the overarching infrastructural partnerships that you talked about, engaging health systems and the community and practices alike to address these core issues is really important. So if there are no further questions, I'm going to thank this very esteemed panel for your time, and then do a final wrap up here with my slides on the evaluation. So thank you to everybody who was here with us over the last couple of days, or if you joined in and out. The final thing I want to say is that we do have an evaluation and continuing education credit request form that's available here in the chat box that you can directly click on, and Oliver will be sending out, following this symposium, a copy of the recording and the slide decks and contact information. And we hope that all of you stay engaged with us at a network, and we hope to stay engaged with you, because to hark on what Yanai left us with, a very positive note, it is about relationships, it's about the friendships, it's about sustaining the work that we're all doing in our state. And so it's an honor and a privilege to be with you all today over the last couple of days. Wish you a wonderful Friday and a great weekend. Thank you.